Welcome back. I'm Krishna Ramachandran, one of the PTAC committee members. This time I'm excited to welcome four amazing experts for our listening session who will share their perspectives on maximizing the participation of beneficiaries in accountable care and improving the sustainability of effective population-based total cost of care models. You can find their full biographies and slides posted on the ASPE PTAC website. I see our presenters have turned on their video. Thank you. After all our experts are presented, our committee members will have plenty of time to ask questions. The full biographies of our presenters can also be found there, as I mentioned, along with the materials for the meeting today as well. So first up, we'll have Dr. David Muhlstein, who's the Chief Executive Officer of Simple Healthcare. David, go ahead.
Thank you. It's great to be with you today and to talk a little bit about what opportunities I see in value-based care and population-based payment models. So I'm going to primarily share some data and talk about some of the trends that are there and opportunities that I view exist today. So next slide. First, we'll start with looking at some general trends about groups. So this is looking from 2013 to 2019, and this trend has continued, though I haven't updated the numbers. But you can see that the percent or proportion of physicians that are practicing in small groups, so on the left-hand side, that's the onesie twosies, has decreased pretty significantly, while those that are practicing in very large groups has grown. And so we see a broad trend that's moving towards larger group practices, which often enable people or put them in a better position to participate in models. Next slide. Subsequently, there is a difference, though, between the primary care physicians and the specialists in terms of the rate that people are moving toward these. So lots of even faster movement with primary care, but slower with specialists. So while there's still a general trend moving from the smaller groups, the specialists are more inclined to stay in these smaller group practices, given the dynamics of how their practices tend to function and the ability that they have to stay in these smaller groups. Next slide. A lot of this, though, is not driven by changes in practice patterns. And this is an important concept where it's not people that are saying, oh, I'm in a onesie-twosie practice, I'm going to go join a 500 group or group. It tends to be people that are leaving the practice of medicine and being replaced by people that have a different expectation of how they practice. So this chart shows a static shot of what's happening. This was in 2018, but similar trends you can see today, where you see that the old timers, the really old doctors that are still practicing, that graduated from medical school 60 years ago, over half of them are in onesie-twosie practices and only 17.5% were practicing in these larger groups. If you go to the other extreme, the recent graduates from medical school, half of them were practicing in these larger practices relative to very, very few that were hanging their own shingle. And so this trend that we're seeing, some of it is by people that are moving practices, but much of it is that an older generation of clinicians is retiring and they're being replaced by a new generation that has different expectations about how they practice, primarily moving to these larger groups. Next slide. There's also a trend about where there's opportunity. And yesterday, there was a presentation that showed some data on how more ACOs are being led by physician groups. A lot of this is because there's, frankly, more physician groups that are capable of forming these ACOs, risk-based entities. This is a study that we did a few years ago, but it found that over a third of all hospital systems that potentially could become an ACO already were, while less than 10% of physician groups that could ultimately become an ACO had been there. So the groups are getting larger, and there's a significant number of them that have not yet joined an ACO or another population-based model. Next slide. So this is the trend looking at ACOs. So if you go back to the early 2010s, there was pretty significant growth, quick growth that was happening. And then about 2018, 2019, when enhanced risk provisions started to happen with the Medicare Shared Savings Program, the growth started to plateau, and it's been relatively stagnant over time. And this is not just because nobody is joining these programs, but it's because now for every organization that joins a program, there's another ACO that drops out. And this is looking at commercial and government-backed ones, so Medicare, Medicaid, and commercial-based ACO programs. But this doesn't mean that there hasn't been a continuing growth of advanced alternative payment models. Next slide. So this looks at the percent of physicians that are qualified participants in advanced alternative payment models, so in APMs. This is people that have qualified under the regulations that came out of the macro legislation. And you can see that there has been very consistent growth. So only 8% of physicians were qualifying in 2017, a little bit more in 2018, back when we saw that plateau with ACOs. And now it's up to 29%, at least in 2023. That's where this article that I published last December had data through 23. And we are seeing a pretty consistent year-over-year trend where more and more physicians are starting to go to APMs. Now, there's two reasons that this happens. One is because current participants are expanding and getting larger. So some of them are adding additional TINs or group practices to their current models. And then there's also new models that people are starting to join. So it's an expansion beyond what I thought about 10 years ago is that everybody that wanted to move to some sort of a population-based model would really be in an ACO or some variation of that. But we're seeing a lot of models that are formed that I really don't think of as the ACOs in the same way that the shared savings program manages a population. Next slide. There is a difference, though, between physicians and non-physicians. So an important trend that is happening, and I didn't put the data here, but the number of physicians practicing in the country is basically flat. It's been flat since about 2017. The growth of non-physicians, so nurse practitioners and physician assistants that are practicing and billing Medicare and taking care of patients is growing considerably. So since 2017, in that same time frame where physicians have been flat, non-physicians have grown by 30%. But when you look at the adoption of these alternative payment models, they are significantly below. Yes, they're growing, but they are significantly below physicians. So non-physicians are just starting at a lower rate and also growing at a slightly lower rate in terms of absolute percentage increase year over year. Next slide. When you compare just among the physicians, the trend has been much more pronounced among primary care docs as opposed to specialists. You look at these numbers and you see that nearly half of all primary care docs have moved to become a qualified participant in an APM, while it's only approaching a third of the specialists. And so I'll come with some recommendations of why I think that is in a few slides. Next slide. This is the breakdown by specialty. So you look at it's a pretty stark difference. So family medicine, over 50% were qualified EPM participants. And you look at ophthalmologists or dermatologists when it's down around 19%. So fewer than 1 in 5 are participating. And the reason for this that I think is a major challenge for a number of specialties is that there are not models that really make sense for how they practice medicine. So if you are a cardiologist, a lot of what you do actually involves primary care. You're managing a population. They just happen to have heart disease, so they might have heart failure, but you're also managing their diabetes, and you're working with any other conditions that come up. They go see their cardiologist and they're feeling sick and they just ask them. And so there are a number of specialties that do have a lot of that longitudinal care and management that's similar to traditional family medicine, internal medicine type specialties. But if you look at other ones, they really do things very differently. If you look at a psychiatrist, for example, the way they care for their patients is dramatically different than the way that a family medicine doctor is going to care for their patients. So I think there's going to be an opportunity and a need really to create some models that are built around the needs of those specialties. Next slide. It's also not consistent where growth is happening around the country. So this is looking at all doctors, all providers, so physicians plus the nurse practitioners, physician assistants, everybody that's billing Medicare, and the percent of them that are qualified participants. And this ranges from below 10% in some states to well over 50% in other states. And it doesn't follow a clean blue state, red state divide. It doesn't follow an urban-rural divide. It doesn't follow coastal versus interior. There's no real rhyme or reason with how these markets are moving towards value-based care, other than when a market starts to move, all of the participants start to think about this and they start to respond to where there might be opportunities to move towards value-based care. Next slide. So this is by the different government-backed APMs around the country. The majority of people that are participating in one of these models are participating in the Medicare Shared Savings Program, but also you see the ACO REACH has a fairly high number of participants, but a majority of people, 56%, still are participating in zero APMs right now. And so while there are a bunch of models, it's really just a couple of programs that are bringing in the majority of people in terms of participation. Next slide. So here are my recommendations. The first one is that for primary care providers, there are sufficient numbers of AAPMs that exist for them. If they are not participating, it's not because they're not aware of them, and it's not because they couldn't, it's because they've made a choice not to. Now, individuals, there might be reasons why not. In certain groups, there might be reasons why they can't join them, but by and large, primary care providers have a pathway forward. This is different, though, for specialists. For certain specialists, I think there needs to be specialty-focused models that are created really around these low participation specialties and say, what do we need to do to get dermatologists into APMs? What do we need to do to get psychiatrists participating? We also really need to think about these non-physicians. There is a significant number and they are growing and they will continue to grow. And the percent of care that they're providing to Medicare beneficiaries and also non-Medicare beneficiaries is going to continue to increase over time. So we need to think about them more proactively than has happened in the past. I think there can be improvement with model hierarchy. There can be confusion when people are participating in different models. I think you could just do a rank ordered list and say, if you're in a model that's higher, then that's the one where you get credit for that, and that's their participation. We could talk more about that during the question and answer. But then finally, I think there needs to be regional focus. What do you do to seed the initial organizations that start moving to value-based care that will bring other people along? Or how do you create a model similar to what's happened, for example, in Vermont, where there's a Vermont-specific model where you create a market-based model that really drives adoption within those regions of the country. With that, I will pass the baton to whoever is next.
Thank you, David. Next, we have Dr. Sanjay Shetty, who is the president of at Centerwell at Humana. Sanjay, thanks for joining us in person. Go ahead.
All right. Well, thank you so much for having me. Really looking forward to the conversation. As was mentioned, I'm Dr. Sanjay Shetty, president of Centerwell at Humana. I'm a member of the management team at Humana. I'm a radiologist by training, but I've been working in value-based care for a little bit longer than that, including running one of the pioneer next-gen ACOs back in the mid-2010s. But happy to talk to you a little bit more about Centerwell. We founded Centerwell basically with the aspiration that we could continue to drive forward value-based care by attempting to provide differentiated and integrated care that would improve experience, quality, and outcomes. Our goal is really to help seniors in particular navigate what we believe to be a very fragmented healthcare system. Centerwell is composed of three main parts. We have Centerwell Senior Primary Care, which includes over 340 primary care centers operating in 15 states, caring for just north of 400,000 patients. Importantly, all of our patients are either in some form of total risk contract or on a path to value-based paradigm. That includes working with many different Medicare Advantage payers, as well as being a participant in ACO REACH. These clinics are really purpose-built to provide value-based care with integrated care teams, longer appointment times, immediate access, really not built at all around an old fee-for-service paradigm, but built if you were starting from scratch to serve value-based care patients, how would you build it, especially for a senior population? And that includes caring for them both inside the clinic, outside the clinic, community rooms where we provide activities, et cetera, to really care for the whole person. Centerwell also includes Centerwell Home Health, one of the leading home health agencies in the nation with 350 branches across 37 states, providing over 8 million visits a year. We have a number of specialized clinical programs that we've developed in order to serve the needs of our patients, including in areas like diabetes and congestive heart failure. And finally, Centerwell includes Centerwell Pharmacy, which is inclusive of a large home delivery pharmacy, a small set of retail locations, a specialty pharmacy, and a hospice pharmacy, overall serving over 48 million prescriptions a year, 2.5 million patients. You can tell by describing these things, I think in some of the materials that I received, this would qualify as a low revenue ACO, right? We're providing care in very distinct areas. So although we don't sort of own the dollar of spend, we believe we have a disproportionate influence on the spend. And that is why we're so engaged in value-based care with these three particular assets, where we're really trying to surround the patient with care that allows us to achieve better outcomes, better experience, better quality. And I did want to point out before I move on from this slide, some recent results that we were able to publish in Health Affairs in association with Harvard. In a study of over 5 million patients, 500,000 patients, we looked at our results as well as the results of other senior-focused primary care providers. And we're able to actually look specifically at this model, not just comparing us to sort of all others, but actually comparing us to other value-based providers and say, what happens differently if you're able to focus sort of cater-made to a particular population? And what we found is that our model is actually helping to provide better access to care and improvement in health outcomes. In particular, we see better access, 17% more primary care visits for senior-focused primary care patients. We're able to see better outcomes, fewer ED visits, 11%, fewer hospitalizations, 6%, and 10% fewer 30-day inpatient readmissions. Importantly, we were also able to see in senior-focused primary care a reduction in some of the health equity disparities that we see more broadly, even among the value-based care group, with Black and low-income beneficiaries having 39%, 21% more primary care visits, respectively. So really exciting work that is also pointing towards improvements in cancer screening, blood pressure control, medication adherence, and diabetes adherence. So really exciting, and what we're beginning to put together at CenterWell, we're excited to continue to develop our model over time. One of the key points I wanted to make by moving to the next slide is that Medicare Advantage is a really important part of our overall model. My big worry about a focus on just one segment of the population is it's really hard in reality to run a clinic around a small subset of your population. For us, we've been able to build a sustainable model because we are caring for patients under a variety of Medicare Advantage constructs, as well as the ACO REACH program. And in fact, Medicare Advantage has in a lot of ways led the way, right? Just sharing data that I'm sure you're all familiar with, knowing that that Medicare Advantage has broadened access to the higher level total cost of care models, category 3 and above, 64% in Medicare Advantage compared to only 42% in original Medicare. And so having a broad subset of access to value-based programs across different payers is really important for practices to succeed. I'll skip over this slide just to go to this one. Humana has spent a lot of time thinking about what it takes to be successful in value-based care. And actually, this diagram that I'm sharing on this slide is pulled directly from our value-based care report that was just published a few weeks ago. As we look across our broad network and the broad base of value-based care providers that we have working with us at Humana, we see a couple of things that are really important predictors of success. The first is that providers have to have access to strong infrastructure. That includes having population health management tools, sufficient staffing to be able to actually manage a panel, not just the next visit, but a panel of patients, and effective electronic health records, and the ability to really mine that information for insights. We also know that our practices need to have models of engagement. They need to be able to manage collaboration. They need to be able to think about metrics at scale. They need to be able to communicate with their patients at scale and have mechanisms in which they're outreaching to patients, again, not just the ones who are in the office, but those that are outside the office. And a willingness and ability to share their data, right? Both to ingest data from other sources as well as to share it elsewhere. For many of our practices, value-based care becomes a really important method of growth. It allows them to set up a growth strategy. It becomes an opportunity for them to think about how they will widen their opportunity for revenue and bottom line in the long run. We also really believe it's important that growth is enabled by stability and predictability in these models. Having a program or a set of programs that they can depend on year over year over year with financial returns that will be sustainable is absolutely crucial for them to both plan for future growth, to make the investments in their workforce, but also to support all of the other mechanisms that you see here on the slide. An effective value-based provider has invested heavily in clinical operations. That includes care coordination. It includes making sure that they have access for their primary care providers so that they're able to increase utilization of the primary care relative to other points in the healthcare system. They have to have an actual functioning ER diversion plan, right? That may be as simple as after hours call, but some way of getting a patient seen so that they can avoid expensive emergency room visits and the likely downstream admissions that might follow, as well as the ability to engage with patients after discharge from the hospital. And finally, performance requires that they're thinking carefully about documentation, as well as really robust internal quality and financial reporting, so that they're really able to understand how they're performing and manage against the various contracts and engagements that they have. If I were to summarize like a couple of other ones that don't even apply on the slide, but which I think are also really important, and I feel remiss if I didn't mention, is the ability to invest in care teams. Our model depends on the fact that everybody is functioning at the top of their license, and that we have put around our providers, that would be it physicians or advanced practitioners, entire teams of social workers, behavioral health specialists, pharmacists, in order to ensure that folks are functioning at the top of license, and that data transparency, data liquidity is absolutely crucial. So for us, some of the key messages, first, we really want to encourage that in any consideration of how we continue to promote value-based care, that we think about the stability of Medicare Advantage in driving expanded participation in population-based total cost of care models. Also, we need stability in MSSP and ACO REACH, right? To the degree that those fluctuate year over year, that is where providers, that is where these clinics, that is where, in general, the strategy can't depend on this model. And that includes predictability in benchmarks, predictability in the quality measures, predictability in the financial returns. And finally, as a general rule, what we've seen is that payments based on just completion of process versus outcome is going to actually weaken incentives for providers to commit. We've seen alternatives, right? So if you can tie the process to the outcome and pay people basically the interim step, that may work as long as they feel like they have skin in the game in the outcome. But paying on process just dilutes the effort against what we really want folks to be investing in. So with that, I will hand it off to Sean.
Thank you, Sanjay. Next we have Sean Kavanagh, who is the Chief Policy Officer at Aledade. Welcome, Sean. Thanks for joining us in person as well.
Thank you very much, and thank you for having me here today. Let's see. Great. So I'm Sean Kavanagh. I'm the Chief Policy Officer at Aledade. I'm going to try to bring two perspectives to this discussion. One is the perspective of my previous job. I worked at CMS for 6 years. I was part of the team that helped design the pioneer model that Sanjay referenced. It was the first total cost of care model coming out of the ACA, and it was at the Innovation Center for the launch of a lot of other models. Subsequent to that, I ran the Center for Medicare, where I was responsible for all the payment rules in Medicare A, B, C, and D, but importantly, also designing and trying to grow the Medicare Shared Savings Program, where we often asked ourselves the question you're asking all of us today, which is how do we make this thing bigger and better? The second perspective I want to bring is my current job, which is I'm the Chief Policy Officer at Aledade. I think it's great that I've been partnered here with Sanjay because we represent two very different but complementary models. CenterWell are clinics that they've designed and built and staffed from the ground up, presumably, from scratch and purpose-built. So you can accomplish a great deal, as I'm sure CenterWell has, by doing that. Ours is a very different model, which is we work with primary care as it exists. So we don't build, own, create primary care practices. We go to existing primary care practices and we partner with them. And the partnership is we're going to help make you successful in value-based care as your partner. We'll provide you the technology, the workflows of various support, data and analytics, importantly, regulatory and compliance expertise, so that you can be in the Medicare Shared Savings Program and be successful. But also continuing a theme that Sanjay mentioned, in our practices, we always start with the Medicare Shared Savings Program, but we try to get as much of their patient panel in value-based care as we can. So of the 2.9, almost 3 million lives that are at risk in our practices, we have traditional Medicare, Medicare Advantage, over 1 million commercially insured lives, and even some Medicaid risk lives. We could have more, but the Medicaid total cost of care models aren't as mature or sustainable as we would like. Let me see. the last couple of years, we've been facing the same question. So David Muhlstein showed a slide that showed that growth in the Medicare value-based programs has flattened over the last 4 or 5 years. We've heard CMS officials asking the question that PTAC's now asking, and we've been asking ourselves, what's happening? Why are we not growing? How do we get more providers involved? And what we came upon and believe is going on is very predictable, and it's the science of technology adoption. We've been very successful in engaging the early adopters. So these are the people who need change. They're not comfortable with the status quo. They're comfortable operating in areas of ambiguity, but they're also feeling some pain. So we got and this is in healthcare, largely primary care, right? Primary care the fee-for-service has failed primary care. So a lot of the early adopters from primary care rushed into the program and have been very successful. The problem is we've plateaued, and now we need to extend beyond the early adopters into the mainstream market. And the most important message we take from the literature is the things that attracted the early adopters are very different from the things that will attract the mainstream market. So hammering home on the same themes that got people in initially is not going to attract the mainstream market. So what does the literature tell us? First, you really need to dominate and engage a niche market. And again, we think even though the numbers are very good for primary care engagement, there's a huge number of primary care physicians still not in the program. The other thing is the data on primary care, in particularly MSSP, is the strongest. So the evidence base of them being able to participate and be successful is very strong. What we've noticed is both in the last couple of administrations, starting with myself, we've often talked in policy terms of trying to get more Medicare spend in value-based care models, or trying to get more beneficiaries in primary care models. But of course, as we've heard in the earlier discussion, the way you get people in is by practices joining value-based care models. So CMS needs to do something that it's not built to do and not very comfortable doing, which is marketing. We need to start talking to the practices about the importance of moving to value-based care. And as I said, the CMS data alone shows that this is the right thing to do and that it's good for beneficiaries and good for the practices. So the other thing we take from the literature is defining the competition. My colleague, Farzad Mostashari, who founded Aledade, when he was at ONC, when they were trying to promote the adoption of electronic health records, they came up with the phrase paper kills. And what they meant was, to engage practices, hey, this stuff you're doing is really bad for you and bad for your patients. We need a similar approach that fee-for-service is bad for practices and bad for patients. The good news is, so to put it in a financial context, last year, Medicare physicians through the fee schedule across the board took a 1.25% reduction in Medicare fees. At the same time, we paid out billions to ACOs, and primary care physician-led ACOs got almost $300 per beneficiary in shared savings. At Aledade, 2 of our most mature markets, our physicians make more on traditional Medicare in shared savings than they bill in fee-for-service. So there's a pathway here for them. And then getting to the programmatic thing. The mainstream market doesn't want bells and whistles. They're not looking to be involved in innovation at all. In fact, when we talk to our doctors, that's a fairly scary term to them. They want to participate in what's the new normal. So we have to make the program the mainstream. And what we've been rallying around and talking to CMS about is, first of all, let's key in on the Medicare Shared Savings Program. We participate in REACH. We think testing new things is wonderful, but make clear that MSSP is the total cost of care destination. It's the statutorily mandated program. It's where the evidence is. If you need, and importantly, if you need to test new things like primary care capitation and things like that, test it in the context of MSSP. Use MSSP as the chassis for innovation, so you're constantly driving people to the statutory program. Assemble the whole product. And what we mean is the people who joined MSSP 10, 12 years ago, they've seen an evolution of the program. The benchmarking formulas changed, and I did it twice myself. in various ways. I think generally for the better, but that level of change and dynamic life is not what the mainstream's looking for. They want to know that you've figured out what the payment model is. And frankly, we haven't in MSSP. We continue to have rebasing and ratchets that don't make this a long-term sustainable proposition. CMS has stated that. MedPAC has stated that. Steps have been taken, but we've got a ways to go. So we really have to nail down the product that we're pushing before we can expect that the mainstream will accept it. And the last thing I would say is the mainstream is not do-it-yourselfers. I think it was Dr. McWilliams on the previous panel who talked about the complexity of the program. The mainstream wants someone to figure this stuff out for them. The early adopters, Sanjay, these folks went in and read 300, 800-page regs. They figured out the nuance of the program. They came to conferences. The mainstream, that's the last thing they want to do. But the good news is there are simplifiers out there who will make their lives easier. It's not for everybody. Some people want to do it themselves. And Alidate is certainly not the only one. But we should make room in the market for the simplifiers. And I think CMS to date has sort of been ambivalent about the role of simplifiers. If not, and I heard previous discussions here where people who came and testified said, actually, the simplifiers are a problem. They cost too much. But the program, the providers are voting with their feet. So when the program started, it was 2 or 3% of the practices in the program were going through Alidate or some similar organization. And now it's nearly almost a third. So without these simplifiers, you wouldn't have the program you have today. So in summation, we need new strategies different from the ones that attracted the early adopters. We need to speak directly and market directly to the practices. Currently, Alidate, MHN, and others are the ones doing the marketing. CMS needs to get engaged in that. We need to focus on the audience where we can make a real improvement, which is first primary care. That's not to say specialists aren't important. We're working every day to figure out the role of specialists in our ACOs, but we have to totally dominate the primary care market in order for this to spread more widely. And then we got to make sure the program's ready, stable, and sustainable in the long term if you're going to get the mainstream to engage. So thank you very much.
Thank you, Sean. Last, we have Dr. Carl Koenig, who's the Executive Director of the Musculoskeletal Institute, Division Chief of Orthopedic Surgery, and Associate Professor of Surgery and Perioperative Care at the Dell Medical School at the University of Texas at Austin. Carl, welcome.
Well, thank you very much. And I really appreciate the opportunity to speak to this esteemed panel and with this group. You might be wondering why an orthopedic surgeon would be coming to talk to you today, but I definitely represent a group of forward-thinking specialists who want to try to help find ways to create appropriate specialist interactions with ACOs. Many of us believe in value-based care models, and we've participated in voluntary models as they've come forward. And so I'm here representing the American Academy of Orthopedic Surgeons to talk about, or at least suggest some ways that we start thinking about innovative payment models that are going to drive the kind of behavior change that we need to see. Next slide, please. No relevant disclosures. Next slide. I just, to put it into context, musculoskeletal disease affects 1 out of every 2 people over 18 and 3 out of every 4 people over the age of 65. It is a major part of the specialty care that our patients undertake, and we have an important role in keeping our patients healthy and active. Also, with that amount of care, obviously, it is a big part of the spend that we have to responsibly utilize together and help our patients move forward. I think, there are some studies to suggest that over half the time that a patient turns the door of a primary care doctor's office is to talk about a musculoskeletal complaint. So the way we interact together with our ACO colleagues is going to be really, really important. And we think there are better ways to do it. Next, please. I want to just kind of remind us all that, value can be increased by either improving outcomes or decreasing costs. And I think we get focused on the costs a lot, which is obviously important, but it's because we feel like we have a little bit easier way to move some of those levers. But it is primarily accomplished by incentivizing the use of effective evidence-based treatments and allowing the patient and the physician to partner in producing better health. So as we try to change this conversation from sick care to better health, We have to have models that promote that type of behavior. And it doesn't mean just finding a way to bolt on a different payment model onto systems that already exist. I think the payment model can actually help drive the system that you want to see. And so the mechanism for appropriate specialty and ACO interaction has really not been worked out. And so, you have most of your specialists living in a fee-for-service world, doing what we've always done. And so I think it puts our primary care colleagues who are trying to set up these models, it puts them at a disadvantage. So right now, since the ACOs are being held accountable for the musculoskeletal outcomes, they don't really have a way to interact with those specialists other than their referral patterns. And then we've tried to, come up with ways, and I know you have, of helping them figure out who the high-value specialists are. But so far, those efforts have not been very successful. And so we're suggesting that it's actually the payment model that can incentivize that kind of collaborative high-value care. And it's going to be the best way forward. Next slide. So, the primary care doctor leads from the ACO, and the specialist would have an opportunity to manage the full episode of care for certain conditions, right? That really gives us skin in the game, allows us to share in the risk, and also allows us to share in the savings created with actually allowing our primary care doctors to get that portion of things that they really don't have much training in off their plate, and allow the specialist to actually be a contributing partner. And so that requires a different type of payment other than just referral patterns into the same fee-for-service area. So I'm talking about condition-based bundled payments, and that is a bundled payment that covers the full cycle of care for something like an acute injury. So if you have an ankle fracture, there's one payment that goes to the specialist for taking care of that entire cycle of care from beginning to end. And if it's a chronic condition like osteoarthritis of the knee, then it would likely be, for a defined period of time for up to a year. But that could include surgery, not surgery, all of the other evidence-based treatments that we would actually use in the care of that chronic condition. Next slide. And so, why do I think these are the best, at least the best model for taking care of musculoskeletal conditions? So the ACOs have really matured at the primary care level, and many are, improving this enhanced coordination, but they have challenges when they're trying to create transformation around specialty care. They're kind of stuck in this world of, do I hire my own specialists and try to manage them from within, and that kind of thing. Whereas I think a payment model can solve a lot of those problems. It can allow people to voluntarily participate. The specialists who want to be involved in health-focused population health approach, and allow them to interact with those primary care providers. So there are multiple different types of stakeholders who can provide high-value musculoskeletal care. But I would really, and I guess our profession would also suggest that unless you can provide the full spectrum of evidence-based treatments within the entity that is taking on a condition-based bundle, that you're not really doing that job. And so orthopedic surgeons are required to at least be part of these teams or lead these teams because we spend the most time in musculoskeletal training and are set up in a position to create models that will deliver for this set of conditions in musculoskeletal care. Next. So just to give you a flavor of what I'm talking about, I'm sorry, I thought I was going to have a pointer, but if you think of a normal patient who is in one of our models who's 68 years old and having pain in their knee, where do they go? They often go to their primary care doctor, which would be the appropriate place to start. Some go directly to an orthopedic surgeon, some go directly to a physical therapist. And as you know, they all bounce around this system where unfortunately there are a couple of major issues. So one of them is that none of these people talk to each other. So there's no incentive for us to have that coordination. There are no mechanisms for us to really have that coordination. But what's most concerning about the current state of affairs is that the suite of treatments you're offered for this problem of knee pain as a 68-year-old is very dependent on where you decide to enter the system. And so we do feel that having these types of payment models is going to allow the creation of patient-centered models of care for musculoskeletal disease. So such as the one that we've created in Austin, which I've spent the last 9 years blood, sweat, and tears trying to create, is really a musculoskeletal team that is set up to support the care of the primary care physician. So our primary care colleagues are trying to take care of, they're the captain of the health ship, and we can take this portion of the musculoskeletal care and deliver it in a high-value way in conjunction with them. And so it just requires a condition-based payment model to do it. But by pushing that patient at the center, you can have the appropriate team for dealing with that musculoskeletal condition, and you can surround them with the appropriate services to make sure that we follow through and deliver on that care. And that's really what we're talking about. Next slide. And so, just as a global look of how this would be, instead of just nesting acute condition models such as, surgery-focused bundles, we're suggesting that we back out to another layer and saying there are certain conditions that need to be moved over into a separate payment model so that we can exist within current ACO structure. Next. Thank you. And this is just a very global look at what something like that might look like as we've experimented with here in Austin is, like a knee osteoarthritis bundle. And so the patient, once that diagnosis is established and they're referred into our team, the patient's treatment path is not dictated by whether they have surgery or don't have surgery or whether they engage with physical therapy or not. Our team takes responsibility for the outcomes of the patient and the resources that we utilize to achieve those outcomes so that we can behave in an appropriate evidence-based and high-value way. And so, for example, the patient on the top line, we're measuring patient-reported outcome measures at the first visit and then again at 6 months and again at 12 months and in between when we need to. But those reporting times are a way that we can say to the payer, hey, here's what we're doing for your population in terms of improving their functional outcomes and pain. And then whether they're on this path where they go into surgery, whether they try physical therapy and then have surgery, all of the follow-up is contained within this. And so that path is one segment, but we're not disincentivized from doing the path at the bottom, which is to do appropriate imaging. Actually, surgery is not the best thing for this patient, but we still want to produce a good outcome for them. And so we're tracking that and we're reporting it back to you. And if you have a pathway like this, then the incentives actually fall on creating a better outcome for the patient, no matter what treatment you use. Flip to the next one. And this is just a way, this is a lot to throw at you in a short time. So if you just focus on the left side of the slide, so this is using a patient reported outcome measure around hip pain. So this is the hip osteoarthritis outcome score. So 0 is the worst pain imaginable, and 100 is a perfect hip. And you can see that, so on the far left at baseline, the population that came to see us within these 2 years had a pretty low score in the 40s on average. And then at 6 months, and then at 12 months, we're able to report back to the payer, hey, we've improved the population on average this much and this much. And if you look at the white and gray bars, we broke down into patients that were treated with surgery and patients that were treated without surgery. And when you look at this, you would say, my goodness, you almost got the same outcomes in patients treated non-operatively as operatively. But that's not what that says, right? What that really says is we're really, really good at figuring out who needs surgery to get better and who doesn't need surgery to get better. And that's the kind of behavior that you want to incentivize. And it takes a condition-based payment model to do this. If you just leave us in a fee-for-service model, then of course, we're only paying attention to the ones who need surgery. So this is just an example. Flip the next one, please. And so just as a suggestion, we've got some templates for how we'd like to work with you on creating these type of condition-based models, but we're basically saying that, an episode price that includes the historical population treated by this entity, and, the relevant services that have to do with the treatment of musculoskeletal conditions would be the baseline of like, okay, we're going to set the target price for the year. And when that patient comes into this practice, this is how we would pay. And that includes, surgical professional fees and that type of thing. And we can adjust it for a patient's population that traditionally was very high volume of surgery versus not. There's lots of ways to do that, but we try to include everything in that bundle. And so all of the related care that needs to be provided at evidence-based treatments for osteoarthritis, or, we can talk about other conditions as well. And then appropriate, withholds for reporting on patient-reported outcome measures. So the success is not reported on what are the volume of patients that you saw or what are the volume of visits that you did, but what are the outcomes that you're producing. And it allows the providers to behave in a high-value way. We're going to spend longer with that patient at that first visit, getting them on the treatment path. We're going to be incentivized to making sure they're doing their physical therapy. We're going to be incentivized at helping them lose weight if that's their treatment plan. So it allows the creation of these condition-focused teams because the payment model incentivizes us to do so, just as some in the primary care side, some of our colleagues were sharing earlier. And then, we suggest that, of course, these would be voluntary models, and there are going to be entities who are going to want to be very involved in these, and they're going to be the ones that step up. And then it becomes very easy for the ACOs to decide who they want to work with on the specialty side because there are teams that are set up to deliver on these models. Next. So thank you for letting me kind of throw that at you, but I'm here to really talk about and discuss with you some paths forward to creating better interactions between specialists and ACOs to allow both of us to behave in the way that we want to create better health for the population. Thank you.
Well, thanks all. Let's get some questions from the committee members.
Thanks so much for that. Couple of questions. So essentially you mentioned outcomes versus process metrics. And when we take a look at Medicare Advantage versus ACO REACH versus MSSP, I think REACH is probably the closest to outcome measures. What are the sort of outcome measures you would want to see across Medicare products that would align more and more with population-based total cost of care improvements?
I think fundamentally it starts with total cost of care, right? And ensuring that you set that up appropriately. So you're not paying someone to, for example, do the post-acute visit in the office, but rather make sure they have the access to actually avoid the readmission, which is really what we're trying to do, as opposed to just do the process step. And so for me, that's where it starts. I would say beyond that, I think we've started to dabble in what matters, right? Which is the actual control of the blood pressure, not the adherence to the medication, et cetera. So my first and foremost would go to total cost of care, and then beyond that.
If I could just supplement that. So take Medicare Advantage stars, for instance. They have both the medication adherence and the outcome, which should be unnecessary. Similarly, there's a lot of transition of care type measures in MA stars where we'd rather see them judge us based on ED admission rates or inpatient or readmit rates. The outcome you're trying to affect through the transitions of care rather than the process of the transition.
So can I maybe just ask a follow-up around that? When we're taking a look at utilization rates, right, specifically, as we think about creating metrics for utilization rates, I mean, that's always been a tricky thing to do, is that how do you create a metric and reward on that, and shouldn't that already be covered in that total cost of care component of things? And so both from you and from those on Zoom would love thoughts on that, or what other incremental outcomes-based metrics can be.
I think you raise a very fair point, and I take MIPS for example. MIPS has all these subcategories of spend metrics that if you're capturing total cost of care, what's the point? We would be willing to even forego some of those utilization metrics because total cost of care is in place. But we're having trouble getting rid of the process measures, so we're trying to go one step at a time.
Next, we'll go to Lee. Questions?
Thanks so much. Great discussions, got my wheels turning for sure. So I'm really interested. I appreciate the, first, I think, really granular elucidation of how a specialty conditioned type value-based model can work nested within a primary care population focused model. I'd like to try to flesh that out a little bit more with the group. So my questions about that are, I appreciate your diagram on page 4. Are we considering this, a specialty condition nested model like your example, it's, related to knee pain, or is it a one step broader, all musculoskeletal condition nested model, right? So it's knee pain now and it might be back pain in 6 weeks. Is that same, or two different episodes in your mind? Secondly, does this only work in a population-based total cost of care model where essentially the risk owner, ACO, for instance, is receiving full capitation, they're offering a subcap for a musculoskeletal model, or is there a way this can operate within MSSP somehow? The next would be where you draw the line, meaning does this only work for the 3 most expensive, the conditions affecting the 3 most expensive specialties in the total cost of care population-based population? Or is there some other metric you'd think about where you draw that line to divide up the subcaps? Thank you.
No, thank you. Fantastic questions. And these are the ones that I spend a lot of time thinking about. I think the reason we have been most focused on something like one condition to get started has been that it seems very, very daunting to anyone that we talk to about, changing the structure of the way we deliver this and, sort of paying almost, paying on outcome rather than, than paying for individual services. So I think, personally, that it could very easily lead to a subcapitated model for all musculoskeletal care. And actually, there are many orthopedic surgery practices. They tend to be the base, but they usually end up being multidisciplinary musculoskeletal practices. If you really look at it, there's primary care sports medicine physicians, there are, rheumatologists, there are physiatrists, all working together in these practices. They're kind of based around orthopedic surgery practices, but I think any of them, and ourselves included, would be very interested in a subcapitation of musculoskeletal spend because, and not to denigrate any of our primary care colleagues, but, we find that our rate of ordering advanced imaging is lower because this is all we do, and we're very focused on it, and we know when it's going to affect the treatment decisions or not. Our willingness to engage in certain, non-value added care prior to certain procedures is going to be less. So we feel very comfortable managing that musculoskeletal spend. So you could go up to that subcapitated level. It seems like the world wants to start with, some conditions to kind of feel it out. But no, I definitely think that's an important one. I think in terms of, do we only do this for the 3 most expensive specialties or whatever? I think it's an interesting question. I think, of course, I think everyone wants to be involved, but there are even certain parts of our world which may never be able to fall into this, so which is, musculoskeletal tumor, right? It's those patients have no homogeneity. It may be nearly impossible to try and do that. So that may also always need to live in some other model, but it's pretty narrow for us. So I think one metric to use is, does that specialty have a lot of things that can't fit, or does it have just a couple things that can't fit? So for musculoskeletal, almost everything can fit other than things like tumor, maybe certain kinds of inflammatory conditions that, from birth or congenital conditions, but almost everything can fit. So that's why I would say this is a good place to start, but also the ability to measure outcomes that matter to patients. So using patient-reported outcome measures is something that we're very, very comfortable with, have been doing for a very long time, and we're actually comfortable measuring our results based on that. And so we actually have a metric to put in that numerator of the value equation, which I think, may be true for others and different and ones for that. So I don't know if I missed one of your questions. It was a very complex question, but that's how I would start.
Anybody else?
Yeah, maybe if I could add, I would say at CenterWell, we're probably at multiple stages of our learning journey on exactly this point. We have the full range. So we have some cardiologists that are employed in part of the CenterWell practice because we found that the need for true value-based cardiology was important and that we could embed it within the practice and improve access and also improve that alignment. We also partner with, we look at our entire specialty network and are very much thinking about who are the high-value specialists out in the universe to whom we would promote referrals. Say, hey, we believe a referral to this doctor is the right place to go. And so we work actively with our primary care providers on helping them understand the differences between the providers that may exist. Very hard to tell if you don't have access to that downstream data in order to understand that. And we are contemplating partnerships with companies in the value-based care space that are focused on specialty care. I think the considerations that we're bringing to the table are very much who is at risk for engagement in a particular model, right? Who is at risk for leakage if a patient decides or is referred outside of that particular partnership? And then something you referenced just now, which is where do you draw the line, right? Is it Part B? Do you add hospital? Do you add imaging? Do you add drug spend? And where does that line get drawn? And then around what conditions, such that you can create a meaningful arrangement, that you can have a partnership as opposed to a mechanism through which someone can try to essentially, I wouldn't say it this way, but game the system, right? It's amazing how you can control cost here, but it's a balloon squeezing. You're squeezing here and seeing it pop in other spots and just happen to not be responsible for it. And so we're very much on that learning journey of how do we develop these relationships that we believe can be sustainable for both sides and deliver on that promise of improved experience, quality, and outcomes.
Sean.
Similar to CenterWell, we're experimenting with a lot of things, but I want to put my CMMI hat back on. And one of the things I would caution is, this is obviously what Dr. Koenig's describing is where we're all trying to get to. Well, there's a technical component to this that's very hard to overcome, which is small numbers. So even when CMMI ran these models and had much larger numbers, they struggled to price right, based on historical data and projections and so forth. When you get to a much smaller unit of service, like a Aledade ACO, which has only 20,000 lives to start with, the numbers get even smaller. The stability of the prices and the fairness starts, and the margin of error grows, and it's just technically difficult as well.
David, did you want to weigh in?
I'll just mention that with one of the challenges that I view with all of this is, I mean, it's this, what has been brought up, what's in, what's out, and how do you say if you're doing a condition specific bundle or conditional specific model, how do you decide if the total cost is related to that? And I think that can be addressed in two ways that could be considered. One of those is just doing full risk adjustment. So if you create a psychiatric model, so somebody has the condition, you're going to manage them with psychiatric specialty, but they also have heart failure. You'd say, well, there's just a risk score where we'd say the expected costs are higher. I mean, this is the same risk scoring that happens in Medicare Advantage, and you could build that into that model. So you say, yes, you are being assigned based on this principal diagnosis, but because of your comorbid conditions, you're going to have a high risk score, and that's going to adjust for it. Another way that you do this is you just do either kind of a stop loss arrangement. This is what they already do at the MSSP, where if you're above the 99th percentile for Medicare beneficiaries, those costs don't accrue to you. So you could figure out what that kind of stop loss might be, or just say that if these are non-condition specific, those costs are excluded from the total cost of care. But I think it's a challenge to do that. I don't think it's impossible. People thought that it was impossible to come up with DRGs and have a set of diagnoses for hospitals, but it's probably that level of effort to kind of do condition-specific carve-in and carve-outs, but I think it's doable.
Yeah, and I would agree. I do not underestimate the amount of effort that this would take, but I think, unfortunately, I mean, we're lacking a way to engage as specialists, and I guess I'm speaking for other specialists who aren't here, but this is my whole interest, is trying to engage with ACOs and trying to create a better, healthier population. I'm not the average orthopedic surgeon in that regard, but having a payment model that's just in fee for service doesn't make any sense. And I agree with you. The risk adjustment is absolutely key, right? We would love to get to a world where the most difficult patients are the patients you get paid the most to take care of, right? At the end of the day, then that takes away this disincentive we currently have to have people engage with those. And working in an academic center, obviously, I see a lot of those patients. But I do think that, taking some piece of this and starting down the road, you're going to find a lot of engagement from, the orthopedic surgeons, and I think many other musculoskeletal specialties. We recognize that, we're getting into a very, very technical world, where we're just doing small parts of this, and the only levers that our primary care doctors have is whether or not to refer patients to us. And I'm truthfully very worried about people being rationed, right? You're not going to get referred to the orthopedic surgeon until it's the last possible thing you can do. And if we didn't do so many interventions that improve patients' quality of life to such a degree, then I could understand that. But, many, many patients are going to have a much healthier, active lifestyle if we can get them treated appropriately. So that's why, we're trying to build a bridge here. I agree.
Thank you. I'm going to go next to Larry.
Great set of presentations. The gears in my head are spinning. I have just a technical question for David. On slide 11, where you showed the country and the states were all various colors, and I was struck by Wisconsin, which is dominated by health systems, and they were one of your, I think it was reddest states. I wonder if you overlaid health system dominance in an area on that map to see if that was driving some of the variation, because a lot of these physicians would gain access to those APMs by their participation in the hospital network.
Yeah, so I can't talk specifically to Wisconsin because I don't remember off the top of my head, but I can say generally we've looked at how a dominant cinema market does influence this. And it's kind of bimodal. It either makes it happen or not happen within markets. And generally, it's the gorilla in the market. If the gorilla starts to do something, everybody else responds to what they're doing. If the gorilla in the market says, we are moving towards value-based care, we're going to move all of our patients or all of our physicians out of MIPS and into AAPMs, then everybody else in that market also creates their own strategy to do the same thing. But on the other side of the coin, if they say, no, we're good with fee for service, they're not the incentive. So they have that potential to do it. I'll use an example. It's the two Rochesters. So Rochester, Minnesota has over 90% AAPM participation. And it's not just Mayo. It's all of the systems that are there that have now moved towards this value-based model. Rochester, New York is one of the lowest metropolitan areas. And those systems there, nobody has said, we're going to take that first step. And if you don't have that kind of seeding event, you don't see the market level adoption.
Leave it to Larry to find one slide and one picture. Walter?
I also want to thank the panelists for a really great discussion. A lot of thoughts as well for myself. I also want to thank the PCDT and ASPE for convening kind of this particular panel in this way, because I feel like there's a great balance between both specialty engagement in total cost of care models as well as primary care based models. I'm going to ask my question first, and then I'm going to give the context of my question afterwards. So I'd love to get Sean and Sanjay's reaction to what Carl just presented, like specialty nested condition-specific bundled payments, essentially within population-based total cost of care models. From a more philosophical perspective, I think, earlier you guys spoke about some technical issues, but philosophically, how do primary care-based total cost of care models feel about something like what Carl presented, right? Because I could see it both ways. On the one hand, it is attractive to potentially carve out some risk and have the specialists take it. But on the other hand, I could also see how that might make it harder for primary care-based total cost of care models to survive. We just heard this prior presenter in the prior session, Dr. Pena, kind of just talk about how hard it is already for MSSP to compete against Medicare Advantage and all the different bites that other organizations are taking from his apple, to make it harder to work. You can have a primary care provider, for example, who's very well versed in orthopedic musculoskeletal conditions, who can provide more advanced primary care in that area, joint injections, for example, that might be dissuaded from doing so if they had the kind of this carve out, whereas other PCPs may welcome this kind of carve out. So what's your take on this?
Sure. I mean, I think you outlined the concern right off the bat, which is I think there's a huge amount of value in continuing to explore these models. I think the ideal state, at least from my perspective, would be to create optionality for groups that are participating, right? So we are lucky enough to be large enough, and I'll correct one thing Sean said. So we do have our own clinics. We also have an enablement arm that's doing other stuff. But given that scale, we have the opportunity to kind of think deeper and to sort of think through all of the complexities of what these arrangements would look like. That allows us to sort of have some optionality. And frankly, a lot of these strategies are not national strategies, right? We're going down into markets because the market dynamic in each of these areas is very different. And so from my perspective, that variance that happens across the country makes it really important to leave open the optionality, right? So maybe there could be a role to say, here's what a model could look like. Here's how we can make it easier for smaller groups to say, I want to think about whether orthopedic makes sense as a subcap, but not to mandate it, right? And not to force it, especially to not force it on a national scale. Well, hey, that might be perfect for me in Florida, but terrible for me in Georgia, for whatever reason, because of a local market dynamic. And so I think optionality is great, but I think you're absolutely right. I think more and more we're trying to think creatively around how can we solve these problems. And forcing this on a group would actually reduce the innovation that's possible.
Yeah, so this is an area that gets incredibly complex. So let me start with the simple part. You know, there's a lot of commonality among ACOs that are successful, and it's usually a primary care strategy. Wellness, prevention and access, transitions of care, some wraparound services. But if this is truly going to be the future of Medicare, it has to get to specialty care, right? The reason you haven't seen more of it is, I think, what Sanjay was touching on, which is our model scale. You know, we're in Malvern, Arkansas, we're in Los Angeles, like we're in very different communities doing the same thing. When you get to specialty referrals, specialty payment, you can't do the same thing in every community. The availability of specialists varies, the relationship of our primary care doctors to those specialists. So in Malvern, Arkansas, we can't shop specialists. You know, we're dealing with the people who are there, and they're probably great. You know, there's not a disparagement, but to the degree you don't have choice, then the discussion of how to have a financial relationship changes greatly. So that's what we're grappling with. And as Sanjay said, it'll be slower. It's technically hard, but what you'll probably see is rather than one approach that catches fire, you'll see a variety of approaches growing up locally. I do think what Dr. Koenig laid out is sort of the conceptual framework that a lot of us use in our heads, but you'll probably see it morphing locally. I mean, in some markets, we would be happy just if our primary care doctors just switch specialty, right? Like, hey, Dr. So-and-so, based on the data, is better care, lower cost. And then what you realize, there's a lot of local reasons, cultural, financial, and other, that make that more difficult than it sounds. And that's before you even get into, and we're going to pay differently. So the pessimistic answer is this is really hard. The optimistic answer is it absolutely has to happen.
Anyone else? Jim?
Thank you. Thank you all for coming. David, I wanted to say a special thank you. We used your slides. I had the privilege of presenting a lot of your information, and I was glad to meet you here today, so thank you. In light of what David has shared with us and to kind of form the foundation of our discussion, you know, part of the journey of this committee is to kind of represent physicians and advise on some technical issues. And I'm curious about, as y'all watched, especially Sanjay and Sean, as you kind of watched that data that David presented and saw where we're still about penetration in the physician community of participation is fairly flat, and there's still half of the PCPs in America are like, hey, this isn't for me. And you've created different models, and I appreciate you coming and sharing with us. I'm curious about what you've learned, what your organizations have learned, and how you might be able to represent what you've learned with regards to the changing motivation of physicians to actually do the next best thing to actually drive value, quality. And I know you presented, Sanjay, you were heavy on the quality, but you didn't share with us on the cost savings within, let's say, your ACO reach, like how the performance was. And so I know that there are a few levers. We've heard before y'all got here yesterday, some discussion about sharing. For example, one of the levers was the sharing of savings, right? We heard Dr. Pena just a little bit ago talk about the difficulties down in the valley about earning savings and then distributing those savings, which is what I was challenged with when I was running an ACO in Dallas. And so I'm curious about what you think is kind of the magic motivators for physician participation, number one, and then engagement to actually say, I'm buying into what you want me to do. I'm in an employed situation now. I'm not necessarily in private practice. And Sean, you have more of the private practice perspective. And so I think y'all would do nice bookends here for us to kind of give us some insights.
Thank you for the question. So yeah, we largely deal with private practice, but we also deal with a lot of community health centers in which the management does the deal with us, but the practitioners themselves are often in an employment situation. So the motivations vary. As I mentioned, the early motivation was early adopters who are like, this is a cool new thing. There's an opportunity here. I was the first on my block to get an electric car. I'm going to be the first to be in an ACO. As you move along that adoption curve to people who are less or more risk averse, then you get to the more negative motivation, which is, I'm going broke. I need a new revenue model. I've already done the part where I see more patients and I'm running hours in the day. I need to make more money per patient. But even for them, there's a leap of faith that 18 months from now, after I do the work, I'm going to get paid. So there's a cash flow problem. But the reason we lose very few practices once they join us, and if we lose them, they tend to go off on their own or go with another enabler, is professionalism. They realize this isn't just a payment model. This is a better way to practice. Because what do we have them do? We have them reach out. We make them more intelligent about bringing in patients who they're responsible for, who in the past, they just waited to come in. Now they're reaching out to them, but with some knowledge. They were just in the ED. They just got discharged from hospital. They need a wellness visit. We make them smart about transitions. So there's a professionalism that kicks in that's important, even regardless of the financial incentives. But we do run into, as you say, like there is the weird financial model, which is our ACOs tend to ramp up and get more and more savings, then CMS rebases us and the finances change. And so running a small practice on erratic checks that come once a year is very difficult. And that's another part of like completing the model. And to the CMS's credit, they're testing a bunch of the flex model, making care primary of trying to smooth, or advanced shared savings of trying to smooth that out. On the CHC side, we're dealing with employed physicians. What we see more there is if you only get engagement on Medicare fee-for-service patients, they're like, we're here. There's much more a mentality there of, I'm here for a mission. I'm here to treat everybody the same. Don't give me a strategy on 15% of my patient panel. So getting Medicaid, commercial contracts, so it more becomes their complete way of practicing is how you get engagement and buy-in.
Yeah, not much to add. I would say from our perspective, so I mean, on the cost side, I referenced in the senior focused primary care, right, the outcomes with respect to hospitalizations, ER, et cetera. So it is, I think, an important part of both the quality as well as the total cost of care outcome. But I would say what our aspiration really is we want to be the type of practice that clinicians want to work at. And supporting them in their work of the day-to-day, I think, is really important. I think, Sean, you said it before, right? Fee-for-service has let down primary care. It is not sustainable to, in most cases, run a primary care practice the way that any doctor would want to run it and just live off the back of fee-for-service. What value-based care does is it creates an avenue to actually be sustainable and to practice in a way that most doctors would want to, which is I care for my patient whether they're in front of me or not. I have a team around me so that I don't have to worry about all the tasks that I didn't go to medical school to do, but which someone can help me with. I bring in other experts to care for all parts of a patient, the behavioral health, the pharmacist, everyone else, where they're actually better at it than I am. And that's okay because my job is to care for them in the ways that I was trained as a physician. And so for us, that itself has been an incredibly powerful motivator in terms of attracting people into our model of care. It's because we are sort of keeping the promise of, hey, their value-based care is not just the payment at the end of the year or the year after. It is investing in all of the work that has to happen along the way, and that is a better place to work. But I agree with what Sean said, right? For the practices that we support, even within the clinics, right, we do create visibility for our providers so they understand how they're performing. That itself is a very powerful motivator, right? For a lot of the docs, right? They were used to being A students and they hate to see themselves on a list knowing that they missed a few screenings and they want to get them done. And that is very helpful. And obviously financial incentives exist as well, both for the affiliate practices we work with as well as with our employed providers, just to help them really connect those dots in the day-to-day. But for us, I think the most powerful thing has been the fact that along with the care model along with the payment model is a true change in the care model and the practice model.
And I want to add as well, Sanjay, because that is actually true on the specialist side as well. Like I get to work in this really unique place where we designed a model approaching population health from that perspective, but I get to practice medicine the way I thought I was going to practice medicine when I went to medical school. I take care of my patients. I call in help when I need it. We're not just there to do surgery. And like today, I just did a hip replacement on a guy yesterday. I called him this morning to not just because I'm worried about the ER. I called him because I want to see how he's doing, right? And so it does allow you to do that. And I just would say that's why it's so, even though it's going to be hard, it's so important that we do this together because we have to get everybody behaving that way and we have to allow the specialists a way to do so. So that's exactly why I'm here this morning. Thank you.
Larry?
Well, Walter asked the question right after me and he got me thinking, so I'll give him credit for this. But I want to address it to Sean. I wrote down a number of your statements because they got me, you know, you need to dominate a niche market. CMS needs a marketing strategy. We need a statement that fee for service is bad for you. MSSP should be the chassis for VBC innovation. You know, those stuck with me. I'm a gastroenterologist. So everybody knows that GI guys make all their money by doing colonoscopies. And it's a very low variation procedure, despite what the GIs would like you to believe. They shouldn't be paid more because they have a better, no, there's not much variation in there. It should be bundled. But 50% of the variable cost of the entire GI space is coming from inflammatory bowel disease. A very expensive illness that only affects 1% of the population, but it's a major chunk of GI. We've heard others in this meeting present, and I love the term, a subscription model for compensating providers. And we've also heard about a hybrid models where fee-for-service is combined with a little subscription model. Have you experimented at all with compensating specialists for cognitive services for patients with chronic disease? Forget the colonoscopies, but using any kind of a hybrid model or subscription model.
We haven't yet done that on the payment side. What we've done in several markets with very mixed results was more just what we called care compacts, where our primary care docs convened the local specialists and said, hey, I'm in an ACO now. This is the incentive I'm under. And I need, you know, so I need to care about how you guys are treating my patients. So I'm going to be looking at data. And if you want me to continue referring, let's have a conversation about how you're going to care for the data so that I can continue referring to you as opposed to sending them to the other gastroenterologist. But it hasn't, those conversations and that model has had some sporadic success in certain markets, but hasn't replicated in other markets, and it hasn't grown to the payment side. Though where it has worked, payment has then come up, which is, hey, we're working together now. Part of the problem is we're paid retrospectively. So, you know, the special, not to generalize, but often the specialists are like, yeah, this notion of waiting 18 months and then taking a portion of an uncertain check is a difficult model. You know, I'm glad it works for you, doesn't really work for me.
Anyone else have anything to add? Hinesh?
So this is to follow up a little bit on what Jim said and thinking about the next addressable market. So we talked about it plateauing and what is the innovators, et cetera, the people who want the first electric car on their block, those are taken up. Then I guess you have two options. One is fee for service, this isn't working for me, and so I need something else. If you take a look at that group, right? I mean, primary care is able to flex quite a bit. Is that they're able to shift from the fee for service to the value-based care structure much more easily. Is that the next addressable market? And then how do we actually incent them to do that other than creating a burning platform of I have to do this? And I guess the second part of it is that the other systems that are there that have large fixed costs, but like the infrastructure. I have the hospitals, I have the ASCs that I've built, I've hired X number of specialists. I mean, need to still be able to be sustained. So how do we, I guess, think about models that would incent them, given the fact that they have fixed costs today?
Happy to go if no one else wants to go first. The fixed costs is a hard problem, but we have, I mean, the cause for optimism is when MSSP in its first couple of years, all the true savings in the program came from physician-led models, and net, the hospital-led models or delivery ACOs were a net drain on the treasury. That has changed. The hospital-based ACOs, they're still not performing the way physician-based ACOs have, but they are seemingly generating savings. So there is some cause for optimism. We've seen multiple reasons for that. Some hospitals are full, so the notion of reducing admissions is consistent with their financial interests. Some would rather be full of commercial patients than Medicare patients, which is, we'll take the short-term win, but that's not a long-term solution. But going back to your original question, which is really what we've spent most of our time thinking about, like, where do we go next? I still think it's I mean, you said primary care flexes, but there's still a long runway in primary care. When I was at CMS and people were like, oh, we could make MIPS really crappy and drive more people into ACO models. And I was like, I hate to have any part of Medicare be crappy. So I was really reluctant to do that. Having said that, Congress did try to set up this dynamic where MIPS is not a lot of fun, and I don't know that they did this on purpose, or very meaningful. And that did drive some membership in our ACOs. Unfortunately, and I've told CMS this directly, they've blurred those lines. A lot of MIPS requirements, which ACOs were supposed to be exempt from, have drifted into the ACO program. So you could reestablish that distinction that not only do we think this is good for you and you should do it, we're going to make it clearer through policy as well. Less burden, more meaningful. The measures will be more meaningful. I can't tell you enough. Like, after time, like, our physicians want a couple of things. Time is a big thing they want. But after that the work be meaningful. And they still we always sometimes disagree about what's meaningful. But on the ACO, they think the ACO quality measures have slowly eroded in meaning because, as I said, more and more of the MIPS type stuff is coming across. So make it more meaningful, more outcomes focused. And I think you'll see take up. And as I said, finish the model, make the financial model clear and, not unchanging, but like established, and get rid of the rebasing and the ratchet effects, which I know your previous panel had Dr. McWilliams, who's been one of the leading thinkers in this area.
So
Go ahead,
yeah,
David.
an area where I think if you look at the next market where you could invest in models that would really impact the broader industry is in GME. So when you look at graduate medical education, so academic medical centers where people are being trained, if they were being trained to practice in the value-based mindset, coordinated care, alignment among specialists and primary care doctors, all of these things that we've been talking about for decades, that sets their expectation of what medicine is and how it should operate going forward. They would then go out to work and they would have an expectation, and they would both seed ideas that are there, but they would also look for opportunities that are there. The slide I showed about how people that graduated from medical school in the 60s all had an expectation that they would hang their own shingle has played out for their entire career. People now say we're going to go to a group, but if they said we're going to go to a group, we're going to practice value-based care, we're going to take care of populations. Over time, I think that will make more of a difference than trying to get somebody that's got 5 years left in their career to switch.
Great insight. So let me end with just one more question, and particularly directed towards Sanjay, but everybody else as well. I'm going to switch to home health. And given the position you're in with being able to, with primary care, as well as having a home health asset, as well as trying to coordinate that care, what payment parameters would be helpful in helping to further that in order to add, sort of more efficiency in the care? And I'd love for everyone else to weigh in as well, even Carl, I know you guys use home health as well.
So for us, home health has been a really important part of how we begin to think about primary care differently. Our agency, the CenterWell Home Health, is a traditional skilled home health, right? So it really serves a subset of the population, maybe 10%, that really has a skilled need in the home. We're broadening that focus to say there's a whole nother group of folks that would benefit from some type of engagement in the home, whether it's addressing social determinants, whether it's a visit, whether it is a post-acute engagement. And so broadening that has been very helpful. But we've had to innovate there on our own, right? So we've created internal within CenterWell payment models in order to allow for that level of engagement in a way that is compliant and outside of the contours of traditional skilled episodes that are paid under the Medicare fee schedule. And so I think what would be useful in that setting would be to create alternatives or create other levels of service that could actually be useful for payers, ACOs, and others to engage with folks that are already out in the field to provide the value-added services that allow us to achieve our goals on the total cost of care side. Right now, it feels like we've had to do it purely on the Medicare Advantage side, where we have more of the levers of freedom to be innovative, have not been able to pursue that on the fee-for-service side because it's so highly regulated. Frankly, this will be true more generally, right? If I were looking out into the future on what I really want to see is home health reimbursement should pivot to a value-based model, right? It is still very mired in fee-for-service, very mired in regulations of minimum visits, et cetera, where in fact, again, I don't want to pay for process, I want to pay for outcome. Keep them out of the hospital. Don't worry about how many times you saw them in the home if you can replace home visits with other types of engagement that yield the same outcome. And so we're working on that in the short term, sort of within the sandbox that we have at CenterWell to sort of think differently. I will tell you the unlock has been amazing. Having home health and primary care collaborating has turned into daily huddles where all patients on the home health service are being engaged with the primary care doctor daily. It is not just sign my order, see you in 8 weeks. It is very much a different model of care. And that's what's been most exciting is to say it started with a payment model. It's turning into a care model and changing the way that our clinicians are engaging. And that's been particularly exciting.
Anybody else? Carl?
I would just speak to it that it actually plays really well into a condition model as well, because when we do surgery, we still want to do it in the most focused way. And in certain things like unplanned surgery, like a hip fracture, for instance, in a patient with dementia, I think we've all seen in our career that when that doesn't go well, right? You get the hip fracture fixed and the patient ends up in a skilled nursing facility for a prolonged period of time, and that cycle just goes on. And it's not even their fault. Like that patient's better off recovering in their home. So if you have a tight relationship with your home health providers and you can feel comfortable allowing them to go and recover in their home after certain surgeries, that's helpful. Or same thing for elective like joint replacement procedures. We've moved from 20 years ago, half those patients going to a skilled nursing facility to almost all of them now going home. Some of them being supported by a home health service. But when I have to make that decision, it is so much more helpful to have a partnered person that you're working with in a value-based contract. So I would highly endorse trying to bring all of those folks into the fold, and it works well for us.
I'd like to thank all 4 of you for joining us this morning. You helped us cover a lot of ground, and it was an incredible session balancing each other out. You're welcome to stay and listen to the meeting as much as you can. At this time, we have lunch break from now until 1:20 p.m. Eastern Time. Please join us then for the public comment period and committee discussion. Thank you.